everybody. Hello, everybody. Actually, this is Jack here, but I wanted to start off with a sincere acknowledgement to my friends and colleagues, Richard and Rob. This has come out, oh, I hear some dog barking in the background already. This has came out of a meeting in Raleigh-Durham in November of last year, December. And at that meeting, after that meeting, Rob asked me if I'd be willing to present again to the New Mind Center. It's something which I really and truly do enjoy doing. It's a great opportunity for me to share ideas with colleagues. And so I thank you, Richard, and I thank you, Rob, for making this possible. So the topic tonight is integrative management of sensitized chronic pain, which we'll call SCP, using autonomic self-regulation, which we'll call ASR. And the two parts then will be clinical and research. Tonight, we'll talk about basic science and clinical aspects of SCP and ASR. And a week from tonight, we'll do the research that we're doing here and take a more in-depth look at, particularly at the variables and what the outcomes are in various populations that we've been using the ASR maneuver on, who do have chronic pain. So, a brief overview about myself then. Of course, I'm a licensed psychologist and neuropsychologist, and I do have a grant right now from the VA to study chronic pain in veterans using ASR. And I have an additional appointment in South Carolina School of Medicine PPN department, and there's contact information for anyone who would like it. So here's my disclaimers and disclosures. I'm not expert in cardiology or pain or medication. I've kind of come at this in the back door, and really, I'm not exactly a new guy anymore, but I still am learning. This was not my original field of study. I trained as a neuropsychologist and have a very deep interest in cognitive psychophysiology, which is what has brought me to the doorstep of heart rate variability and related topics. I have no conflict of interest, affiliations, or product endorsements to share with you. All my slides will be available, our original, and were available on the internet, where I have given acknowledgments. Anyone is free to use them, and I just ask for acknowledgement if you do use any of these slides. I'm going to be presenting a number of different models, which are intended to be didactic. And just to sort of anticipate, you might say, or proactively and be ready for any particular type of debates, these are intended to be heuristic, and they are correct as far as they go, and they're consistent, but they are also incomplete and simplified. I'm not writing a textbook for medical cardiovascular psychophysiology, and this is not a research proposal. So what I'm getting at here is there's some questions that I think would not really fall within the purview of what it is I'm trying to do here. So we're also going to talk about some interventions, and these are modalities that may be beyond the practice of certain people. It's going to be up to you all to decide what your responsibility is then for reviewing your scope of practice with respect to your credentialing and your competence to practice these interventions. So here's my list of most wanted, you might say, but I never forget the people that have helped me get to where I'm at today. So the reason for all of this was the opioid epidemic, which got going great guns several years ago. It may be subsiding somewhat now, but as of 2015 and into 2016 and even into 2017, it was a huge, enormous problem in terms of mortality, human suffering, costs, morbidity, work days, and so on. From a psychology point of view, it's easy to imagine how addiction can go out of negative reinforcement, where medication, which is originally prescribed to reduce a negative state, where the contingency there is reinforced to take medication to relieve pain, which then becomes positive reinforcement in place of other types of positively reinforcing rewards. Pain medication addiction does include suffering due to stress and depression, in addition to unrelieved pain and behavioral dysfunction. And so we need to replace positively reinforcing characteristics of medication with something else. And this positive reinforcement here is where I hope to fill in this box here with ASR, with the biofeedback. So that's where we've come from. So where are we going? Well, let's talk about sensitized chronic pain and autonomic self-regulation first to define them, talk about their physiological bases, and then sort of a model of how it works. Sensitized chronic pain is associated with stress and depression. Not all pain is the same. Just take a step back now here, a simple basic foundation to understand pain. There's nociceptive pain, which is caused by activity in neural pathways in response to potentially tissue damaging stimuli. So this would include, for example, hitting your thumb with a hammer, where there's tissue damage or something which is impinging upon, and the mechanoreceptors in the skin or in the periphery then sense this as noxious. So there's the prefix there, noci or noxious. Whereas neuropathic pain refers to some type of lesioning or dysfunction in the nerves themselves, as opposed to the surrounding tissue that impinges on the nerves. And there are a set of different but somewhat often overlapping conditions, but they can be distinguished. So nociceptive pain does have certain types of conditions which are not neuropathic, and neuropathic pain can also exist without having nociceptive pain. So there are these two large areas then, or domains or types of pain, and we have to keep that in mind then as we talk about, or what we mean when we talk about pain. So the simple model here, and the one that I think is best used for the ASR maneuver, is nociceptive pain, where again that's the tissue damaging type of pain, where we have peripheral nerve receptors, and which are connected, of course, to the spinal column, the spinal cord. When there is a signal from the periphery to the spinal cord, it synapses once here in the dorsal horn, and then begins its long trek upwards to central nervous system. And this synapse right here is very key in the dorsal horn, where we have glutamate receptors that are issuing neurotransmitters into the synapse, as well as substance P from the mu opioid receptors. The signal is then sent along spinal column to central nervous system, which is then treated as a form of stress in various cortical areas. Right here, the somatoform, somatosensory cortex. And then we have descending modulation. So the brain responds, it says there's something bad, the tissue is damaged, we need to do something about it, and this descending modulation then sends down a whole brew of neurotransmitters to try to dampen the signals that are being received from the C fiber at the dorsal horn, as well as the transmission of neurotransmitters in the dorsal horn. So brainstem nuclei and forebrain on spinal transmission of incoming peripheral pain signals includes, importantly, periaqueductal gray, serotonin, adrenergic, and dopaminergic. So that's the normal model of pain. You have noxious stimulus sent to spinal column, synapses sent up through central nervous system, where it's processed, and then a signal is sent back down to try to manage the pain here in the spinal cord. Well, the common types of antidepressant medications operate at different points along this pathway here. The antidepressants, which are very often used for pain, chronic pain, include amitriptyline and duloxetine. We see that in the clinic a lot. They increase the descending pain inhibition from catecholamines. So you're increasing, you might say, the brakes here. You're stepping on the brakes a little harder. And so with this, these particular types of medication or agents, you get increasing descending modulation of pain. The anti-epileptics, which are also very, including gabapentin, reduce pain by limiting release of glutamate from this synapse here in the dorsal horn. So what we're doing with these medications here is at the level of spinal column, again, reducing the signal which would be sent to central nervous system. And lastly, the opioids, the 800-pound gorilla in the room, they block pain. They have two areas of effect. They block pain at descending modulation as well as in the transmission, in the synaptic transmissions, by binding to mu opioid receptors and inhibiting substance P here, and by activating descending pain modulation here, which also inhibits P. So they're very effective then in dampening the pain signal, which reaches central nervous system. Well, if we step back then and take a little larger system view here, we bring in inflammation and nerve injury, which also stimulates, is stimulated by nociceptive information. And here's the same, it's just really a different view of the same model. Pain comes in from the periphery, it's processed here in the spinal cord, sent up to the brain stem. It's appraised cognitively here. This S1 is somatosensory cortex. The acute pain, and this is where we depart, and this is where some of the key elements are to be found of the overlap of the stress and the pain systems, and why ASR seems to have a place here. Acute pain will increase arousal via the sympathetic and glucocorticoid routes. So right here now we're starting to look like stress, whereas the signal here is coming in from nociceptive impingement on nerve tissues. Stress similarly, which might be external and be perceptual, or maybe environmental, maybe loud noises, or be it what it may, but it would be external. But once we process here, we now have a stress response that begins to descend. So alongside of the descending pain modulation, we also have a stress signal that is being sent out. And in this case, the origin of the stress signal is not external, it is a pain signal from nociceptive. So we get the stress response after there's pain. And that's going to take us briefly, at least, we'll digress quickly into the stress system. There are two major stresses, stress system or information stress responding systems, the sympatho-adrenomedullary system and the hypothalamic pituitary adrenal one. They operate on slightly different time frames and they have slightly different functions. They try to serve the same goal, though, which is to dampen or to create an immediate stress response in order to provide necessary resources in terms of physical management to any type of stressor, as well as to operate in a self-limiting system or a feedback system, which would then shut itself off when stress is over. So they do operate on slightly different pathways and different time frames. The HPA is on a longer scale. The SAM is very rapid, and they operate through different. So the fight or flight is actually a very rapid response, whereas the HPA, when it gets generated, is after minutes or hours or even days that the HPA then becomes chronically engaged. So we have different endpoints here, although there is a very similar endpoint too, in that they both do end in the adrenal glands. So here's yet another model. In this case, there's an external stressor, and we can process that stressor either through the SAM system, which I'm going to show you a little bit more about in a minute, or through the HPA system. So they both end in the adrenal glands, but they in different areas of the adrenal. So one is in the cortex and one is in the adrenal medulla. And of course, this is the HPA and this the SAM. So you can look at it here, and you can see where corticoids, mineralocorticoids, and glucocorticoids originate from adrenal cortex after processing through the HPA, whereas the SAM works slightly differently through dorsal horn again, and these are all sympathetic, adrenergic, epinephrine, I should say, I'm sorry. Yes, adrenergic impulses here, which will then excite the medulla and release epinephrine into the blood system as well as the kidney. But over here is where we want to focus right now in looking at how it is that pain, chronic pain, begins to activate and control or influence the HPA stress response. Well, let's look at it one more time, a slightly different view here. Same idea, stress impinges and is processed in central nervous system. This is the head, the trailhead of the HPA axis, goes through pituitary, ACTH descends onto adrenal, and we then get release of glucocorticoids, mineralocorticoids, and importantly, the cytokines, which are the pro-inflammatories. And inflammation plays a very large part in pain signaling. So when we have any kind of stress response here, ACTH is going to the adrenal cortex, triggering release, first of all, of glucocorticoids and the pro-inflammatory cytokines. And then if that stress continues on, you see here the feedback system is operating normally. The glucocorticoids will then be sensed in the hippocampus and periventricular nucleus. So these glucocorticoids now have been circulating. The brain says, well, we've got enough of them. We're stressed out. We're stressed up. We've had enough. And if the stress ends, the system will shut itself off. And the same is true for the mineralocorticoids. They have a different kind of pathway to shut off the stress response. But the two together then, as you can see, the mineralocorticoids are operating through, again, glucocorticoid receptors in hippocampus, but they're operating on different agents, different neurotransmitters. So the stress response here, which includes quite a number of different transmitters and modulators, will shut itself off when the stress ends, and that's a good thing. Well, if we have pain as our stressor now, in addition, we have the descending pain modulation, as we mentioned. So we have a basic stress response to which we have added this very crucial component here to the spinal column, which is intended to directly act on nerve transmission here in the spinal cord. When the pain ends, the stress response ends, the pain will end, pain signaling ends, and we're back to homeostasis. Well, let's say now that the pain does not end. And we can begin to imagine what's going to happen now. Let's say that we have a constant source of pain. This is nociceptive pain, and it's following the pathway that I outlined before. And we'll add to it, just for good measure here, to really ramp it up. We have some neuropathic pain in there too, which is also chronic. Well, what's going to happen? Of course, the HPA axis goes into chronic overload and continually now is generating cytokines, glucocorticoids, mineralocorticoids, and we reach a point where the system will not shut itself off anymore. We begin to have resistance up here. We have glucocorticoid resistance in hippocampus. We have proliferation of the cytokines. So when we get into this state here, where the pain does not end and the stress response does not end, we have central sensitization. And this is what's meant by sensitized chronic pain. The pain does not end, the stress does not end. We have HPA overdrive. We have loss of glucocorticoid inhibition of pro-inflammatory cytokines, proliferation of peripheral inflammation, heightened pain, disinhibition. Right here, we lose the descending pain modulation, so we lose the nociceptive braking. We run out of catecholamines, which are crucial for this descending modulation here. And so we now have a whole different state or profile, a whole different neuromodulator profile. And that is equal to depressed behavior and mood and can be called the immune runaway train. And very recently now, it's also known that T cells are also involved in the inflammatory response, and really all the literature now really emphasizes inflammatory, including gut microbiomes for that matter. But inflammation is a part of all sorts, almost every type of morbidity, including all the mental disorders. Alzheimer's now is being seen as inflammatory. And a part of that inflammatory response includes T cells. And the new finding is that there are immune responses in the brain, that there is a pathway for T cells to undergo passage into brain tissue. And I think this will be a really important aspect of all of the disorders that involve central nervous system in the future. Well, to go then back to our original model, we now have our model of nociceptive neuropathic, but now everything is sensitized. When we have chronic pain, we have this different state. There's no more homeostasis, or you might say there's homeostasis at a different level, which is being driven by the constant pain stressor. And we can kind of look at it this way. In the inner circle here, if we have some type of acute injury, we have the inflammation and the whole normal stress reaction. And now we begin to bring in central sensitization in through chronic. When acute injury and pain becomes chronic, we now begin to have a self-perpetuating cycle, which spins off into an outer circle here. And now we have more complex behaviors such as sick role, secondary pain, PTSD, mood disorders, cognitive disorders, substance abuse, maybe the addictions, disabilities. People begin to have total disruption of social systems, family systems, primary systems, and possibly even complete system breakdown here if the pain is uncompromising enough. Breakdown of the entire immune system response. This is not a pretty picture, and the chronic pain cycle can be thought of like that. This is from Roland Gallagher's talk at the AAPM 2 or 3 years ago, and is on the web. In sensitized chronic nociceptive pain, descending top-down modulation is lost. Neuropathic pain can be centrally sensitized. It's an interesting thought here to try to, those are pathways I have not even addressed here. And neurologists even think that migraine headaches have central sensitization. Well, depression is an expression of this chronic stress in humans. Rodents show stress in behavior. Humans show stress in behavior and mood. Chronically stressed rodents have a neuromodulator profile very similar to depressed people, but animals, of course, cannot report mood. Depressed people are stressed and can report depressed mood, but not all stressed people are depressed. That's an important consideration here, meaning that central sensitization from pain will express very similar profiles to stress and also depression, but depression is really less characteristic of the chronic pain syndrome than is chronic stress. The difference between stress and depression in people appears to be cortisol. When cortisol is high, depression is expressed. When low, stress is the phenotype. And in this article here, they've lined up findings from clinically depressed humans and chronically stressed rodents. And you can see that the neuromodulator profile is virtually identical on quite a number of modulators here and indicators of chronic stress and depression. The difference being that cortisol is thought to be decreased in PTSD. This has been a controversial finding, but I think is beginning to be accepted, although there's still, it's not totally proven yet or demonstrated, I don't think. So what are the types of presentations then of central sensitization or sensitized chronic pain? Well, things like chronic abdominal pain, chronic fatigue, joint pain, low back pain, nonspecific, tension and migraine, fibromyalgia clearly is a sensitized chronic pain condition, irritable bowel, multiple drug or food allergies or intolerances, chronic pelvic pain, POTS, temporomandibular myofascial pain, whiplash, and nonspecific pain. These all have an element of sensitized chronic pain, which will therefore include stress and depression. So moving on then to what the next topic here, which would be our autonomic self-regulation. What are we going to do about it? How can we deal with this situation in some effective way, not using the opioids and their obvious problems, and not being dependent on other types of medications to a great degree? Well, that's where autonomic self-regulation would come in. I want to give you an overview of what I mean by autonomic self-regulation. And here we go. So heart rate variability, chronic pain, and rehabilitating autonomic nervous system. So it's only a small jump to go from autonomic self-regulation to heart rate variability biofeedback. And while they're not completely interchangeable, they are very strongly, very largely overlapping. So this is from an article that my friend and colleague Ron Garbo and I got into the magazine of the American Academy of Pain Management. Well, autonomic self-regulation does include HRV biofeedback, which essentially is based on resonance frequency breathing, but it includes, importantly, mindful attention and the positive emotional state. So when I say autonomic self-regulation, I'm not meaning let's just do resonance frequency breathing. While this may be useful and is useful in a lot of conditions, and even with the mindful attention, you see this quite often in a lot of training programs, coaching programs, life coaching programs, optimal performance. I think to go the whole hog here, the full Monty, we have to have the positive emotional state as well. So I'm staking out this claim here that autonomic self-regulation includes these three elements. All are necessary and critical components. So the coaching elements then is the paced breathing of resonance frequency and production of coherence through biofeedback. And we'll talk quite a bit more about what this means, HRV coherence, in just a minute. Mindfulness or imagery, focused on breathing in the heart, focused attention on air entering and exiting. This is really just a mental discipline. And however it is you visualize this, whether you use the term heart breathing, or whether you just become aware of interoceptive processes, it's a matter of what the mindfulness teaches you to do, which is to become very aware of focused attention and non-judgmentally to observe, in this case, your own breathing. And lastly is the positive emotional state. You occupy your mind with thoughts of compassion, gratitude, appreciation. I think this is essential. This PES here, positive emotional, can express itself as love and prayer, as happiness. This is really an individual component here. I think the wise ASR coach spends some time finding out what is the positive emotional state of this particular individual, of this subject or this client or this patient of theirs. What is it that gives you that positive emotional feeling? It might be, and quite often is in our veterans, their dog. They just have to think about their dog, and then they get these feelings. They get this, what we mean by positive emotional. Whereas for another individual, it might be saying a prayer, or it might be thinking of a loved one. So this is not really standardized. This is individualized. But it's a necessary part, I believe, of accomplishing a full measure, a whole system, whole health. Whole health, I think, requires effort on the positive emotional state. So during the coaching, really the subject or the person is going back and forth between mindfulness and positive emotional state. And you're sort of blending these two here so that your mindfulness on your own breathing is infused with your positive emotional state. And this then it lies on top of or integrates with the HRV resonance frequency breathing. So a quick review here of HRV and HRV heart rate variability. I suspect we have a very pretty sophisticated audience here, but it's based on the pulse, and whether you use an ECG, which is a PQRST complex, or a plethysmograph, which has a blood pressure volume wave. It's the time between pulses that are measured from landmark to landmark. And if the landmark is an R, we often call this SDRR, but if it's any other normal landmark, it's just landmark to landmark, we call this SDNN. And you can see here, if we have an average heart rate of 60 beats per minute, where every IBI is 1 second, we have 0 variability, but we still have 60 beats per minute. But if we vary these IBIs, 0.9, 1.0, 1.1, 1.0, 0.9, back up to 1.0, we can still get a beat per minute, an average of 60, but here you see there's variability. And this is the variability that we're seeking, and this is what is natural and normal and healthy to have in a normal heart. And these variations here, the difference or alternations between acceleration and deceleration, between short and long IBIs, is governed by the two branches of the autonomic nervous system. Sympathetic drives cardiac acceleration, and parasympathetic drives cardiac deceleration. And this interplay here is very rapid. It can be on the scale of seconds or even shorter. It can be microseconds in the case of parasympathetic. In the case of HPA, the sympathetic overdrive, it's really pretty tonic, and the changes then are relatively long term. And you can reach this state of HPA overdrive or tonic sympathetic state or sympathetic over-arousal. Cardiac acceleration is mediated through the sympathetic nervous system using noradrenaline or norepinephrine. They're the same onto the heart, other organs, and throughout the circulatory system. Deceleration is mediated through parasympathetic nervous system through the vagus nerve, which is called vagal tone, which outputs acetylcholine onto the heart and other organ systems, notably the gut. The pacemaker control of the heart is sympathetic or adrenergic. So if we stop all the parasympathetic, we get the pacemaker at work, and it probably runs around 130, 140 beats per minute. It's very rapid if there is no braking or parasympathetic on it. The cholinergic, that is the vagal output, is added and withdrawn very quickly to lower the pacemaker. So there's a chronic or a tonic, you might say, vagal tone, which lowers the pacemaker down to our normal resting heart rate, which may be anywhere from 60 to 70 to 80 beats per minute. And normal function then is when additional sympathetic adrenergic control is exerted on a slower time scale, the pacemaker rate of heart rate is not reached unless parasympathetic influence is abolished by blockade. So what I'm saying is that we take the pacemaker, we lower it with addition, engagement of parasympathetic, and then we add and withdraw vagal adrenergic to get the full range of heart rate variability. So we don't live at the level of the pacemaker. Well, when vagal tone is withdrawn, we reach a sympathetic overdrive, which gives us a heart rate of, let's say, 80, 90, or maybe 100, which is not healthy and is not normal. So we want to have a good balance here between sympathetic, parasympathetic. It's commonly thought of as the fight or flight. There's some truth to that, although that's a simplification. It is not wise, I think, to consider the autonomic nervous system to be a simple balance or a teeter-totter, where if you have more sympathetic, you have less parasympathetic, and vice versa. There are a number of different homeostatic states that you can have where one is not reduced and the other is lowered. And so it is not a zero sum. The autonomic system is not a zero sum or balanced system. And you can see this here, where at different levels of sympathetic and parasympathetic activities, the amount of each one of them can vary. And this is can be seen here. A change in one branch may cause an increase, decrease, or no change in the other branch. So here's what it looks like now when we actually look at heart rate over time. This is not a good or a healthy heart. And this is a heart which has a fairly nice a rhythm there that you can see of acceleration, deceleration over time. There's a big drop right there. Remembering that if these are RRs, these are inverse to heart rate. So this is actually an acceleration of heart rate because the IBI here has decreased significantly. I don't want to worry too much about the quantitative aspects of it now, but just to say that there are oscillations here that can be observed where we're going up and down in these IBIs, in consecutive IBIs. So this leads us to this important idea that I'm hearing a lot about now called the left foot braking. The two branches are related by a complex nonlinear function. As I mentioned, a change in one may cause, that should be AN, and increase, decrease, or no change in the other branch. Imagine that you are a race car driver is the analogy. And you need to keep your speed up, but you also need to go into a turn. Well, you don't want to go into that turn full speed. So what do? You use your left foot and you tap the brake. This is equivalent to vagal tone or to introduction of acetylcholine or parasympathetic. You slow down just momentarily, but you don't take your foot off of the accelerator, which in this case is the sympathetic system. This is a good model when you're thinking about sports performance and how quickly you can recover, for example, in between plays in football or in between plays in baseball or whatever sport you might have where you're alternating between arousal and some quick recovery and then to regain a very high level of arousal and performance. And that's left foot braking. So HRV is the indicator of autonomic function. Variability is equal to variance, which is maximized when the beat-to-beat intervals increase and decrease in a smooth rhythm that approximates a sine wave. A smooth sinusoidal rhythm of IBIs is characteristic of a healthy heart under resting conditions. The amount of variability is related to a number of factors like respiration and inter-individual factors such as age, gender, height, and fitness. The inter-individual variation in heart rate variability is pretty large. So one person may be quite healthy at a given level of heart rate variability, which is just defined as variance as the IBIs, whereas another person may have a very different level of variance and yet have the same level of what we would call healthiness. So if we now tried to make this into an idealized curve and generate some numbers using a sinusoidal curve, we see that this is what it would look like ideally over a 10-second period. These would be what the values of heart rate would be if it ranged from a mean of 65 beats per minute with a high and a low or max and a min of 15. So ranging from 50 to 80 beats per minute over a 10-second cycle. This is perfectly achievable. This is perfectly normal. There's nothing that's beyond what many people are able to achieve in terms of their heart rate variability and their sinal wave, but it does have to be carefully regulated. So what I want to show you here is that you can see how the IBIs, as we go across a curve here, a single cycle, a single 10-second cycle, it's very hard to see here, but you can see it real clearly here, how these IBIs are short, 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 and then they begin to lengthen, 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 and then they begin to short, short, short again. And that corresponds then to this sinusoidal cycle and what we think of then as the basis of coherence, which we're coming on to right now. If you have a heart that is varying max to min regularly, uniformly over some period of time, ideally around 10 seconds, you have a healthy heart. It is related and controlled by respiratory cycle. And the important point here is that you can get different types of sinal curves depending on the rate of respiration. There are two important factors that control successful breathing and its effect on heart rate variability. One is the diaphragmatic breathing. You have to breathe the right way, and the other is you have to breathe at the right cycle. In diaphragmatic breathing, if you don't already know it, the diaphragm descends, and this is muscular activity, and as a result of pulling down, this negative pressure here will draw air in, and that's exactly the way the lungs work. The diaphragm pulls down, air, in this case the diaphragm is relaxing, and here the diaphragm is expanding. The only way you can see that is if you have to look very carefully. Oh, that whole thing's really annoying. From here to here, you can see how the level of the diaphragm has lowered. You lower your diaphragm, pull your diaphragm down, and it pulls air in. When you then relax the diaphragm and let it return, that is, move upwards, air is forced out. That's diaphragmatic breathing, and it gives you proper ventilation and the right oxygen and CO2 balance, which is necessary to oxygenate the blood and keep a balance here of oxygen and carbon dioxide in exhaling. Now, regular breathing produces respiratory sinus arrhythmia, or the famous RSA, which goes by different names: respiratory pump, cardiopulmonary reflex lung heart pump, but they all lead to the same effect. Respiration produces a rhythm of cardiac acceleration and deceleration. When you inhale, your heart rate will increase. When you exhale, your heart rate will decrease. Again, this is looking at individual IBIs. So single heartbeats will change. Another way to think about this is as a bellows. When we pull the two arms of the bellows out, increase the volume here, air is drawn in. When we squeeze the bellows together, air is forced out. Well, that is the basis of the Bainbridge reflex. This is starting to look a little too complicated to try to cover right now, but I'll give it a go. Respiratory, it's all, the controlling equation here is that cardiac output has to remain constant, and it equals stroke volume times heart rate. So the circulation system needs to maintain a constant level of pressure throughout. Respiratory activity influences venous return to the heart. Increasing the rate and depth of respiration promotes venous return and enhances cardiac output. Well, when cardiac output goes up, then heart rate goes up. Inspiration expands the right atrium, lowers the pressure inside the lungs, and will enhance venous return. There's less pressure against which the returning blood is facing in order to re-enter the heart. Arterial baroreceptors throughout the heart are innervated by vagal afferents, and they respond to atrial filling and contraction. This is the venous return. Increased stretch caused by increased venous return increases heart rate via medullary activation of sympathetic activity. This is the Bainbridge, and increases heart rate. During exhalation, right atrial contracts, increases pressure, impedes venous return, and heart rate slows. During normal breathing, you see this rhythm of increase and decrease in heart rate on individual IBIs. Now, mind you now, this is at regular normal breathing, which may be 10, 12, 15 breaths per minute. The stretch receptors here, when you inhale, the stretch receptors now get squished, you might say, and the volume increases, but the pressure decreases because the volume of the thoracic cavity is increased. And so the venous blood now returns more rapidly, and heart rate will increase in order to keep the circulation pressure constant. So when you inhale, you have decreased thoracic pressure and increased venous volume, heart rate, and blood flow. As you exhale, the thoracic volume decreases, pressure increases, that slows blood flow back to the heart, and so your heart rate will slow. And there you have it. You start all over. This is RSA. Now, it occurs at relatively rapid breathing rates. So we're not at resonance frequency breathing yet. And that's where we're going right now, is into resonance frequency breathing, which is a special rate of breathing. At resonance, we find that we get that the oscillations, in this case, the max to min, the oscillations of the heart rate over the respiratory cycle. I don't think I have it illustrated here, but they increase. At resonance frequency, the maximum heart rate and minimum heart rate within a single respiratory cycle will increase. Pushing a person in a swing is an example. You have to have the timing right. You have to make your push at the height of the cycle. Otherwise, you'll interrupt the cycle and actually slow it down. But if you input extra energy or resonance at the right frequency, then you increase the amplitude, in this case, the size of the swing. And here's a graphic that just shows that it is the baroreceptors, which control blood pressure, arterial blood pressure, that generate this resonance frequency. What I mean to say here is that heart rate variability is coming from two sources. It's coming both from baroreceptors, and largely from baroreceptors, and also from the Bainbridge type of RSA. And the two added together is what creates the natural rhythm of max to min in IBIs. So when coherence is attained, the spectral peak occurs around 0.1 hertz, and you can see how that equals 6 cycles per minute. It's about 6 breaths per minute. So if we generate an ideal curve, we can transform this 6 cycles per minute into a frequency, and we'll see that 0.1 hertz is also 6 cycles per minute. This is a graphic representation of this. This is a time series, and this is a frequency series. It's the same data. RSA and baroreflex together produce heart rate variability. The RSA is small amplitude. You have acceleration on inspiration and returns only to resting heart rate on exhalation. Frequency range here is around 10 to 18 breaths per minute, and here that is in hertz. This is the upper range of the spectrum for people who are doing heart rate variability. Resonance frequency and bringing in the baroreflex has much larger amplitude changes. They can be very large, as much as 30, a max to min of 30 in a well-trained athlete. Increases the max and min of heart rate over the respiration cycle. That is, deceleration goes below resting heart rate, and frequency range is down here around the 0.1. And you can see this here. If we have shallow, rapid breathing, we do get oscillations here at 30 breaths per minute, but we have an average max to min of 2. As we slow our breathing down, the amplitudes begin to increase, and so does the max to min. And then when that baroreflex kicks in and blood pressure also begins responding in synchronization with respiration, now we get these very large waves. And this is due to the added parasympathetic input from the baroreflex, which is controlling arterial blood pressure and vasomotor tone. So you have a complete system synchronization of heart rate, respiration, arterial blood pressure, and vasomotor tone. Coherence is an emergent concept. It exists in parallel at physiological from the bottom up and from top-down level of motivated behavior and consciousness. Now, I love this. My friend Ray Hawkins wants us to remember that coherence originally only referred to the mental discipline aspect, the mindfulness of it, and yet it's the same term. So mindfulness, as we think of it, is defined as moment-to-moment, non-judgmental awareness. And when we do mindfulness in ASR, we are become aware of our own internal or interoceptive processes. And mindfulness has definitely achieved a place in the medical practice. It's going nicely. And next, and the third leg here of the stool is the positive emotional state, which includes positive psychology. As you know, there's a resurgence of positive psychology. Seligman back in the 90s, famous for great research on learned helplessness, now is championing positive psychology. It finds its way into several different types of therapy and has been associated with gratitude. But I'm here to tell you that there's a lot more ways than gratitude to create a positive emotional state. I think it's indicated by oxytocin, which puts it right into the middle of the camp of the polyvagal theory of Porges, where in the higher stage here, we have communication, self-soothing. This is really the flip side, the other side of the coin of the oxytocin release that comes from affiliation. Well, here's what it looks like then in practice. Two setups where we have the coach, we have somebody, the fingertip plethysmograph here, looking at the feedback. We have positive emotional state, mindful attention, resonance frequency breathing, all impinging on HRV, producing this coherence, which is the system-wide synchronization. Does it work? You bet. We can take a guy, this is real data from our study. He came in breathing or with his heart rate looking like this. And after coach, it looked like this, and his spectrum went from something like this to something like this. That's the 0.1 peak. He's breathing at the right cycle. He's using the diaphragmatic breathing. He's getting these very large amplitudes, max to min. He's created a healthy heart rhythm. And here's the same type of data in just a different, more sophisticated equipment. That was ECG, and this was the pre-training, and this was the post-training. A real poster child here. So here are the nervous system pathways that are shared. Let's think back now to sensitized chronic pain. Somatosensory cortex is in both. The HPA axis is in both. The adrenal cortex and glucocorticoids, part of the stress response, and the pro-inflammatory cytokines. So here then is the model of management of sensitized chronic pain with autonomic self-regulation. Chronic pain plus ASR leads to increased heart rate variability, which means increased parasympathetic nervous system, which leads to a decreased stress response, leads to decreased inflammation, and decrease in sensitized chronic pain. All right, I'm coming into port now. I've got a couple of minutes left, I believe. Honestly, I don't have a clock or a watch handy, but with what time we have left, I'll be happy to try to take some questions. Rob, are you there?
I'm here, Jack. Yep. We'll start to maybe unmute people, but if people want to type in that, I won't be able to see the chat box because I'm on the panelist side with you. So we'll slowly unmute people and see if there's any quick questions people might have.
I'm getting there. Takes a minute to get them all unmuted.
Dr. Ginsberg, can you hear me? It's Victor McGregor.
Yeah, Victor, we can hear you.
Oh, okay. So this is not a sophisticated question, and I know you didn't mean to minimize the role of gratitude when you said you're here to tell us that there's more than gratitude. Because I just note as I get older, the role of gratitude seems to play a more important part in realizing what I have to be grateful for, and for, especially for teachers who guided me along the way. So I'm curious about the role that values play in your model.
emotional state, I think it would be less effective if we said that the third leg should be gratitude. Now, there's no quibble that gratitude is a positive emotional state. And for many people, that is the value which will produce the needed component that you have to have, I think, to have whole health, including heart rate variability. So I don't have any quibble at all with what you're saying. I would only say that for many people, it's gratitude. For others, it might be something else. It's just different ways of getting to the same place. So I hope that sort of addresses your question here. I certainly wouldn't minimize gratitude. And I think what the savvy coach does is to assess their individual person and find out if it's gratitude. Then during the course of training, what you want to help that person to practice and become very fluent in is generating that state, feeling that emotional state, whatever it may be, as a way of maximizing or optimizing your heart rate variability and optimizing your self-regulation, your emotional control, reducing the stress response. So what's important about it is that whatever it is, that you find out what it is for that person and lead them there over and over again so that they now feel very comfortable and easily and quickly will adopt whatever that value state is. Are you with me?
Yeah, 100%. Thank you.
Okay.
All right. Any other quick questions?
Yeah, this is Rick.
Hi.
Hi, I enjoyed your presentation very much. Thank you. Very physiological. I'm a physiologist, so I really appreciate the physiology you put in there.
Okay, I hope I didn't make any big bad mistakes.
No, excellent. My question is, there's this thing we call coherence in the QEEG. So what we need to know is, how does coherence in the QEEG and coherence in HRV, how are they related? Is there a way to get that to get both EEG and HRV coherence?
Bravo.
Coincide.
Marvelous question. Lots of us would like nothing more than to record both simultaneously. Doesn't seem like it'd be that difficult of a thing to do, and there are people who have simultaneously recorded. But let me give you my 2 cents. I'm getting a little bit of static here, but let me give you my 2 cents on that. Here's the way I like to think about it: that if we think of the alpha state, the EEG, the sort of the classic old-fashioned alpha, as being your relatively slow, relatively large amplitude waves with eyes closed and drowsy. Okay, am I okay so far?
Yes.
All right. We want to move one step. We want to open our eyes. And what do we get? We get the alpha blocking, but we're not to beta. So what we have now are relatively low amplitude, but slow. Still we have slow waves. Now, if we not only open our eyes, but we get aroused, we start thinking about something, maybe we get upset, we go into the beta. And so we're moving from, correct me if I'm wrong, but we're moving from synchronized into desynchronized EEG patterns.
Right.
That, to me, is probably a fundamental sort of a correlate. When I think of when I imagine what the EEG state would be, I think of it as being alpha blocking, where you're not in a fully desynchronized state. You're not aroused, but you are prepared. And the best way I think about that is as vigilant. You're looking, you're waiting, you're alert, you're prepared. So to me, heart rate variability coherence is defined behaviorally as being in a state of preparedness, readiness, vigilance.
Wouldn't that be more? So wouldn't that be more in the synchronized state than the desynchronized state?
Well, I don't know where it's at as you're going from one to the other. I mean, let me ask you, describe what your feeling is about what is the behavioral state of of alpha versus beta. How would you qualify those or describe those?
Well, clearly the alpha state, as you said, would be the quiet state of vigilance, and certainly, lower oxygen consumption.
Well, you see, I'm not saying, no, I don't think drowsy is vigilant. It's somewhere in between. We don't want, when we produce this coherence in heart rate variability, we don't want people who are relaxed and drowsy, and we don't want excessive parasympathetic in that system, because then they're not ready for action. And that's what I mean.
Let's look at it let me ask you this. Let's look at it quantitatively. So you said at 6 breaths per minute, we should get the maximum in a normal person. 6 breaths per minute should give you the maximal HRV coherence.
That's generally true, yes. That's
point 0.1 hertz.
That's right. Now, I don't think that translates, I don't know that that translates physiologically or mathematically into the frequencies of alpha or beta brain waves, if that's where you're going.
No, but if we knew that, then, if we knew that it did, if we can identify experimentally that it did.
Right. Well, exactly. And
that would,
that's
to me, be the state of coherence, wouldn't it?
Yes, it would. And if we could record simultaneously, we're doing this really interesting study that I want to tell you about next time, where we're trying to create a state of vigilance and preparedness for reaction. So we present stimuli, and people have to they're waiting in anticipation to see what the stimulus is and then to decide what their action is. Now, I want to carefully delineate vigilance from action. So when you're waiting for the stimulus, you are in what I think is maximal coherence. Once you initiate any kind of reaction to it, even if it's a no-go, once you begin to respond to it, I believe that you're really going to move into the beta state. Now let me ask you, is the beta state more highly synchronized or desynchronized than the alpha blocking?
More desynchronous.
It's more desynchronous. And so that's why I think that it's alpha blocking before we get completely desynchronized. But we don't want people to be drowsy and relaxed. They have to be attentive. They have to be alert. They're looking for the stimulus. So visual scan is a very excellent experimental paradigm to produce vigilance. And heart rate variability is maximized. I suspect that's where alpha blocking is maximized too. So if you and I do an experiment together, what we're going to do is we're going to create a paradigm where we can put subjects into a maximally alert, attentive, vigilant stage and just record heart rate, respiration, and EEG.
And it might be different for every person.
Well, I think that the resonance frequency does vary, but it's not that great. But what would vary, it's not the respiration rate, it's the amplitudes. So an older female would have a much lower max to min than a robust 30-year-old male athlete. However, that's not to say that whatever an older person, whatever the gender and the age is not at their optimum health level. That's the point that I'm making about that. I couldn't tell you, I wouldn't even make a prediction about what the brainwave signature would be.
I see. Good. Good. Thank you.
All right.
Okay.
Yeah, we'll wrap it up for tonight. As a reminder for those still here, he'll be back. Jack will be for part 2 on March, I believe it's 26th.
That's
Monday,
right.
March 26th. So it'll be part 2. Jack, thank you so much. Great presentation as always. Much appreciate your time this evening. And if you want to shoot along your PowerPoint slides,
Yes.
I'm very glad to disperse them. Just shoot them to me
Yes.
and I'll pop them up. Yep.
Are there any other questions that you got, Rob, that didn't get out?
No, we
Okay.
don't have the questions here. We'll just pick up maybe next time with other questions people may have.
Sounds good. I'll keep it shorter and leave a little longer time than at the end to try to pick them all up.
All righty.
Thank you.
Thank you, Jack. Good night, everybody. See you
My pleasure.
Wednesday.